Good afternoon, friends, and thank you, Dr. Ravi Ranjan, for believing in me and giving me this opportunity. Dear friends, as we all know, that surgical intervention by DCR is the mainstay treatment for epiphora resulting from nasolacrimal duct obstruction. And the goal of our DCR surgery is to re-establish canaliculi outflow by creating a bypass into the nasal cavity. Initially, or why say initially, even nowadays, DCR is performed as an external procedure. And it still is a gold standard. But ये दिल मांगे मोर, वाटरिंग तो बंद हो ही जाए, वो स्कार भी ना रहे तो और अच्छा. So over the past few decades, several advances in technology have enabled us to perform this procedure with better cosmesis. At the very outset, let me declare that I have no financial interest in this presentation. And also, my acknowledgement to Dr. Satanshu Mathur, Director, High Tech Institute and Laser Center, Kashipur, Uttarakhand. I have borrowed his slides. More recently, minimally invasive techniques like transcanalicular laser-assisted endoscopic DCR have gained popularity. Now, what is this TCLD? Under endoscopic guidance, osteotomy is made with the help of diode laser. That's all. Advantages. Let us talk about the advantages of TCLD. Now, currently, TCLD procedure is performed with an incision-free technique. Actually, we don't need any incision for this. And this avoids visible scarring, requires short surgical time, produces less bleeding, and it's also easier to learn than the other DCR methods. I have enumerated the advantages: bloodless surgery, quick recovery time, OPD procedure. Yeah, we use topical anesthesia. Medial canthus is preserved in the surgery. Repeatable. If one fails, we can repeat the surgery. Another advantage, we can use it in a failed DCR or DCT cases also. And what are the equipments? Special equipments which we need? Just an endoscope and a fiber optic probe. Optical fiber. The fiber optic probe which we use is 600 micrometer. It's semi-rigid. And to avoid complications like secondary burn in canaliculi, puncta, or eyelid, in the eyelid, we use a metal guide wire. The laser, let's talk about the laser which we use nowadays. 980 nanometer wavelength, commonly used diode laser. We use diode lasers nowadays more commonly. This diode laser works in contact mode only. It creates evaporation and coagulation at the site of contact only. Case selection is again very important. It should be avoided in patients with deviated nasal septum, medial turbinate hypertrophy, canaliculi blockage, and acute dacryocystitis. Anesthesia. What is the anesthesia which we use? Topical. Mixture of lignocaine with adrenaline is used for nasal packing, at least 15 minutes before the surgery for 5 minutes. And local by infiltrating a mixture of xylocaine with adrenaline in the nasociliary area to block the infraorbital and infratrochlear nerves. I'll show a video. Again, this
topical and local anesthesia. anesthesia, nose is packed with mixture of lignocaine with adrenaline for 15 minutes before surgery. Local anesthesia is given by infiltrating mixture of xylocaine with adrenaline in nasociliary area, blocking infraorbital and infratrochlear nerve with the injection of 1 ml of anesthesia.
Next. What exactly do we do in this laser DCR? What do we do? Under nasal endoscopic guidance, laser fiber optic probe is introduced through the upper or lower punctum, passed through the canaliculi, medial up to the medial wall of the lacrimal sac, and an osteotomy is made in the lacrimal bone, of course, using laser power, and this thus bypassing the nasolacrimal duct obstruction.
Sir, be fast.
This we have already said. This can be avoided.
Because we are running short of time.
Two things I would like to highlight. Intubation is important. Intubation for at least 1 to 3 months should be there. Without this, laser DCR is almost certain to fail in 2 to 3 years. Osteotomy. The size should be adequate. Less than 5, chances of failure is more. Adequate size should be 8 to 10. Site of osteotomy. Ideal site is anterior superior to the inferior attachment of middle turbinate at the level of canaliculi, common canaliculi. Some of the complications are highlighted here. Occasional bleeding, eyelid hematoma, preceptal cellulitis, false passage, lacrimal sump syndrome, canalicular stenosis, tissue necrosis. No surgical procedure is without complications, and so some of them are here also. Causes of failure, this we should remember. Scarring of soft tissue surrounding the surgical fistula, synechia of the nasal mucosa, small size of the osteotomy, canalicular occlusion. But if all things go well, be happy, no more tears. Thank you.
Thank you, sir. Thank you, sir.